So, dear colleagues, dear students, dear IASTAM members, ladies and gentlemen, good afternoon, good evening, and good morning. Greetings from the Baltic Sea, Northern Germany, from Kiel University. I'm Angelika Messner, and it's a real pleasure for me to welcome you to this webinar in my capacity as president of IASTAM. The increasing presence of Asian medicines in Western societies is not just related to COVID-19 pandemic. This presence, since many years by now, required specific attention to the encounters between clinicians and practitioners of biomedicine and of the world's traditional healthcare systems, including Asian medicines. Understanding these encounters in local context and disentangling the complex interactions between theory and practice generated by them requires all of the diverse skills of IASTAM members, and by now we are more than 300 members worldwide, both as researchers in our various disciplines and as practitioners whose work is informed by our research. And now it is well known, and it's a matter of fact, that all over the world, besides biomedicine, also researchers and clinicians in the world's traditional healthcare systems, since half a year by now, have contributed with large-scale efforts in order to cope with SARS-CoV-19. These professionals have been performing ongoing research, protocols, and clinical treatments, and they have met with clinical success. However, there is still not much known about the very background and the details of the workings and conceptualizations of these successes. The social media do not put these rather complex issues at the forefront of their stories and news pages. This might have to do with the fact that crossing borders in terms of languages, regions, historical and anthropological insights, and medical practices takes time and dedication. And what's more, it requires also historical knowledge and careful attention. This is what our webinar series aims at. It brings together world-class scholars and practitioners of Asian medicine from different continents and countries, languages and expertise to present their research and their clinical insight with regard to SARS-CoV-19. In other words, the expertise brought together crosses medicines of different Asian localities or regions, Chinese and Tibetan medicine today, of different regional uses in Beijing, in China and in the US, and offers fine-grained knowledge and insights from the history of pandemics past and present. Now, let me congratulate Michael Stanley Baker and myself also for bringing together 4 highly recognized scholars for this IASTAM webinar today. And thank you so very much for your time and commitment, Martha Hansen, Tony Tidwell, Thomas Avery-Garand, and Shelley Oakes. Looking forward to our lectures and a vivid discussion during this second IASTAM webinar today. And let me again warmly welcome all of you. I now turn over the floor to Michael Stanley Baker in Singapore. Michael, you have the word.
Thank you, Angelika. And thank you, everybody, for joining from all of your different time zones, from the early morning in Minnesota, to mid-afternoon in Europe, to late evening here in East Asia and Southeast Asia, and everywhere in between. It's a great pleasure to be able to join with this world community. And I'm very particularly honored to be able to host 4 spectacular scholars who've been doing incredible work on this urgent topic of COVID-19 and how Asian medicines have been responding to it, and its predecessors, in fact, because we'll also hear, I think, also about SARS from 2003. And in these reflections, I think it's nice to contextualize where Asian medicines has shifted into in terms of its discourse, partly leading up to the COVID-19, but also particularly exacerbated during the pandemic itself. Not 10 or 15 years ago, Asian medicines were considered important if marginalized medical approaches, which are underrepresented in some quarters. if not subject to some criticism from some sectors of the scientific community, there's also a great deal of openness and interest and support. In IASTAM, we discussed how we could provide a platform to reflect on these different representations and approaches. We saw integrated medicine, which offered many potentials, but itself also seemed to privilege a biomedical approach and limit the use of different regional epistemologies. Systems biology also seemed to offer potential for closer dialogue across different epistemological domains and to bring practitioners closer together to talk about clinical realities. Other experimental modes have emerged in the last decade, such as the Translating Vitalities project, which has produced many interesting reflections from historiography, from clinical understandings, even from the arts, about how to translate and communicate different understandings of the body and its treatment. We've also had representatives from the society speak at the World Health Symposium numerous times in symposia on medicine and culture. And recently, of course, the Nobel Prize awarded to Du Youyou for her discovery of artemisinin, after reading a 4th century Taoist medical text, produced a lot of conversation in 2015 and 16 about the relevance of traditional epistemology to the scientific techniques and methods that were used to extract artemisinin. Yet, in recent years, Asian medicines have also become to be perceived as a threat. As Angelica mentioned, popular media articles tend to focus on Chinese medicines in particular as a threat to endangered species, on the burgeoning multi-billion-dollar economy. And with the rise of anti-Chinese fears in most recently, advocacy of traditional Chinese medicine, at any rate, has been politicized. So that those who advocate it are seen as tantamount to forwarding Chinese state agendas, which very often could be quite the opposite. Cautions are raised about lack of studies and dangers of using drugs that are not fully tested, or partial alleviation of symptoms without achieving a cure, all of which are also viable warnings and measures to be considered when using Western medicine, using biomedicine. Nevertheless, as described, they portray Asian medicines as uniquely threatening and dangerous. And I think this particular tenor has taken hold, especially with the development of new tacit forms of, or very explicit forms of racism under the cover of the pandemic and regional terms for the disease. I'm refusing to use WHO affirmed terms. I think there's potential, and I think it's important. This is why we found it vitally important to have this seminar, to provide some breathing space, to provide an epistemological forum where we can listen to and hear these epistemologies and their practices and how they've been playing out in reality in clinics with much more comparative space. And that is really the part of our intention here. Not as this is just because this is going on video and this may be used later. I want to reaffirm something that was said at the last seminar, that an outright complete advocacy of Asian medicines is not the goal here. The goal is rather an advocacy of the consideration and deep reflection on Asian medicines. And that's really the critical thing that is at stake and that's missing in the current discourse. Unfortunately, I wanted to send you links to some of the great work that people have been doing, particularly our first speakers, Thomas Avery Garin and Shelley Oakes, who translated a slew of studies, of publications, of national and local protocols for dealing with COVID-19 in Chinese context. So I'm just going to say you can find that at Passiflora Press. If you look it up, it's P-A-S-S-I, Flora Press. And I also want to mention at this point, in case I neglect to later, that many of my students, for example, have been reading this week in anticipation of hearing Marta here. Marta speaking her earlier reflection about COVID-19, about SARS, titled Conceptual Blind Spots and Media Blindfolds, which is now sort of a standard fare on North American Chinese medical syllabuses. And I think this, and what I'm looking forward to is the next stage of that conversation that we had about SARS and where we're heading now with the new kind of, I don't want to say normal, but the new context in which we'll be engaging with Asian medicines. So without further ado, I really want to invite you all to welcome Shelley Oakes and Thomas Avery Garin, who will kick off the seminar today with, or the webinar, by presenting, we'll have a video presentation which will be played from Kiel, I understand. And then each session will go for half an hour. So we'll hear from Shelley and Thomas first, and then we'll hear from Tawny Tidwell, and then Marta Hansen, and then we'll have half an hour for general conversation at the end. So I'll hand over to Thomas and Shelley via Kiel.
Okay, welcome everybody. Good morning, good afternoon, good evening. I'm Garin with Shelley Oakes. Already left. I recorded over slides, so I'm just going to introduce and then she's going to take over. So we're going to talk about the role of traditional Chinese medicine in COVID-19 prevention and treatment effort in China, and not just in Wuhan, but also throughout the country.
So first of all, it's important to recognize the massive mobilization that Chinese medicine was a part of. We want to give a little bit of a picture of that greater context. And part of that is certainly in numbers. So an average of $3,450 was spent per patient, much more when those cases were severe and critical. And overall, almost $200 million had been spent as of the end of May on all of the prevention and treatment efforts. So what we're focusing on today is really the medical teams that were sent to Hubei and specifically to Wuhan. 42,000 medical personnel from other parts of China were mobilized and sent to Wuhan. Those were people who were sent through their regional governments or sent through their work units, their hospitals, and so on. And beyond that, there were also volunteers who were not paid to go. And just some of them spent their own money to drive to Wuhan. So this was a massive effort. And part of that was 5,000 Chinese medicine. So when we think about those numbers, it's also important to think about the nitty-gritty sort of everyday reality of epidemic control. So this subway car is empty. This is from April, because the city of Beijing, when there was about 30% passenger volume compared to normal, they ran the trains and buses at 70% to keep them empty. And for every industry, there were regulations about what you could do to prevent transmission. So you see this elevator on the right. This has tissues. Sometimes there were toothpicks, and you could take one, press your button, and throw it away to prevent contact, because it was recognized that we all, touch our faces and our eyes and mouths more than we realize. And so there was an effort to try to prevent transmission through contact. This is a classroom. This is my daughter's 6th grade classroom. And this is not from February or March. This is the first day of school, September 1st. And at this point in Beijing, all children in grades 1 through 9 are required to wear masks. Obviously, there's no social distancing per se, but unless they're outside playing, they have to wear masks. And that's probably going to be continued throughout the year as a precautionary measure. So you see all over China, and certainly all over Beijing, particularly the first half of the year, lines reminding you of social distancing, disinfection going on. Whether that really works in the outdoors, I'm not sure, but this is the kind of thing that you would see all over the city. And testing, tracing, and monitoring seem to be the keys to controlling the epidemic, looking at the experience of China, but also looking around the world. And so every province and certainly every major city has an app that you download on your smartphone, and you're required to show it. It's certainly less strict now, but I still need to show this to get into my building where I work at a full-service medical clinic. And there's also a survey that the hospital I work at also requires the employees. So I have to say that I'm showing a green light today, and this is my green light, which means that I haven't traveled to any high-risk areas. And it also means, because it's for Beijing, that I don't live in a compound where there have been positive cases. So I think it's also important to really recognize that the grassroots effort was organized by higher levels of government, but it was carried out by many, many provinces all over China because people were staying home, particularly the elderly, out of concern for getting the disease. People would deliver food, people would deliver medicine. Certainly, taking temperatures and passing out masks and so on was a part of it. But all kinds of stories have come out of this. People who use their own time, use their own money to provide either medical workers or patients with what they needed. In rural areas, this is the kind of scene you would see because there were not enough officials or police or anything on that level to sort of be posted at every border. This red line here happens to be a border with Hubei. And so you had volunteers asking people, where they were going and where they had been and asking them to sign in and out. So this bottom-up cooperation is something you have to keep in mind. I know a lot of people are skeptical. There's a general skepticism about statistics that come from all branches, as it were, of the Chinese government. However, in this particular case, I think if you understand, or certainly if you have some firsthand experience with the level of cooperation, it really makes the statistics much more believable. There's a very high level of cooperation. Part of that in the beginning was certainly due to fear or natural aversion to disease, and also concern over expenses and lingering physical damage because it wasn't clear. People were afraid that, like SARS, there would be lingering damage to the lungs. In fact, right after the outbreak began, there was this long article going around social media about people who had taken massive amounts of steroids during SARS and were sick for years afterwards. So there was a concern, but there also was a genuine willingness to sacrifice oneself for the greater good. So I think it doesn't have to be just one thing, and never is in any individual or population. And these are just some sort of conclusions that Thomas and I have reached, certainly not based on surveys, but based on just our convenience samples, if you will, based on our own experience here. So this was something that was included in so many different aspects of life. The Gaokao, the college entrance exam, included a question about Chinese medicine, battling COVID. These are posters from children. The one on the right, the one on the left is elementary, and then this high school student got creative, making him look kind of like an astronaut. And the other one is a pamphlet aimed at children, telling them how to take care and to sort of defend themselves against the virus, which is also often depicted as a little sort of demon or goblin. And this is a popular cartoon. And what it's really trying to say in its particular way is when China was sick, the world was watching, and when other countries were sick and China had already successfully controlled the epidemic, this is what should have been happening. And then the final slide on the far right says, the reality is like this, or this is the way it really is. And the message here is, you didn't listen to us. You didn't take this seriously enough. So there's tremendous politicization of the whole thing on so many different levels, whether it's public discourse from lowbrow to highbrow, and certainly on the level of government. But this is also on another level just a common sentiment that people have. People feel in China that they've sacrificed, or I should say at least the people around me, they've sacrificed, and that there's a certain unfairness because other countries have not done the same thing. So at this point, again, because of the politicalization, the government has crystallized its narrative into our system works better, and the fact that we controlled the epidemic successfully shows this. So there's the idea that the Western democracies didn't make good on that part of the social contract which says you should protect your people and provide services, particularly in a crisis. And in China, they did. So it's a simple narrative when it's presented to the larger population, you know, because propaganda is, of course, made for the whole country, including people in the countryside, people in rural areas that may only have a middle school education. So they draw those lines for you. They don't leave that for anyone to do. So these are two sides of the same coin. We did it successfully. This shows that our values and our system are superior and work, and they, particularly the US at this point, has failed. And so that also means that their system fails. The system is not workable, it's not efficient, and ultimately it violates people's human rights. This is the argument, because they don't protect people when they need to be protected. So to what extent is Chinese medicine a part of this greater political narrative, of the ideological framing of the epidemic? I would say that it's a small piece of the epidemic pie. I've been looking, you know, are there ways in which it's being framed as this is the Chinese solution to the epidemic? But the Chinese solution is presented as the whole thing, as all of the efforts of the lockdowns, of the testing. Recently, of course, with the local outbreak in Qingdao, they tested 9 million people in a matter of days. And we experienced that in Beijing in June when we had a few cases. Every compound had a notice, apartment compound, going up saying you can be tested. So they also tested 10 million people in a very short period of time here in Beijing. So the narrative around Chinese medicine then is that it worked, that it was useful for fighting the epidemic. It was a significant part of it. And there are two ideas that often appear in lockstep, which is it was effective, so we should promote it internationally. It had a role in China and around the world, and so it should be globalized. And then the last is that it should be utilized more in the future in the healthcare system in China. And I'll talk more about that in a few minutes. So Thomas is now going to discuss what actually happened with the medical teams that were sent to Wuhan.
So the other thing that they had to do, of course, is like I was talking about in the hospitals, they had to come up with a triage program. And so they divided everyone into 4 basic classes, people that were feverish, febrile, suspected cases, people who had close contact with infected people, etc. And each of those groups were quarantined in different areas. And so this was a way to be able to manage it. And everyone in the hospitals who had not been exposed were taken out of the hospitals, including a lot of staff. So prevention, prevention, really, I want to talk about prevention on a continuum with treatment, because really, how do we classify prevention? In this case, it's really difficult to do because of the somewhat chaotic nature of the situation and the vast numbers of people and the fact that it was a relatively unknown disease at this point. It was basically an unknown disease at this point, and we didn't really know what was going on and what the future might hold. So basically, one of the important things that they try to prevent, 2 major sort of prevention protocols, if you will, and that was to prevent people from contracting disease, and those are basic basic ways of dealing with these kind of infectious diseases, including quarantine and washing hands and so on and so forth. The other thing is preventing the disease from progressing, and so looking at these 2 markers and using this principle of putting this large formula together, or this formula together to give to large numbers of people, they went forward with this idea. So this was done in the Wuchang model. And the formula is called cold dampness formula 1. There's another name to it, and we're going to look at the formula on the next slide very briefly. So basically what this meant is that there was a formula that was put together based on the primary symptomologies. It was based on a Wenbing principles, and there was 4 modifications added to it. So there was some availability to modify the formula according to symptoms, including continued fever for more than 3 days, coughing and asthma, digestive problems, and shortness of breath and fatigue. And so with those, with this main formula and these 4 modifications, they found a local herb company, and this herb company put together these decoction bags. So basically what that means is they create this formula, they boil these herbs up in a huge vat, essentially, and then they are portioned out in bags for individual doses to patients. So in that first night, they actually gave out 27,000 doses, approximately. So this is a very common model that's used in China nowadays, which I think was originally developed in Korea, actually. So so this is the this formula, also called the Wuhan anti-epidemic formula. And so, I don't want to get in. We don't really have a lot of time to talk about the formula itself, but I want to just sort of mention a couple things. So you can see that the first 5 lines, the second and third one are the same, have the same title, minister, but these others are sort of the way that the formula is constructed. And so these, the salvian herbs are the ones that are the sort of primary herbs in this formula, and then each of these other categories sort of support those in some way or another. And so due to time, I don't really want to get into too much about that. And then you can see in the bottom here that, I do want to mention one thing though, actually. Notice that the second line of the minister category of herbs is about the spleen and dampness. And so when we look at those herbs from a practitioner's point of view, what we see is quite a significant array of herbs that are dealing with dampness in different ways. And I think that this speaks a lot to the way that the steering committee and the others that were involved in putting this formula together looked at this disease and realized that it was a rather complex disease. And they wanted to make sure that they were doing something that was going to address as many different aspects of what could be going on. Keep in mind that these 3 doctors had been involved in a number of epidemics previous to this time, including SARS, and so they're pretty well versed in dealing with this kind of medicine. So then these formulas, like I've already mentioned before, these modifications, I don't really need to go into those too much. Unfortunately, because of the logistics of boiling these herbs and portioning them into bags, within a few days, it really, so the decoction started on February 3rd, but within a few days, they realized that it just was not logistically possible. It's like physically impossible for them to keep up with the formula production, with the formula bag production. And so they switched over to these granule extracts. And these extracts are basically just dehydrated decoctions, more or less. And so what this allowed for is formulas could be made without using the process of the decoction, the time and energy that it took to do that. And so this model that you see here is pretty common, is getting more and more common these days. It's a sterile environment, so the herbs are going from these tubes into bags, and then the bags are given to patients. This formula actually also had we have a little bit of data from this formula. So there were 721 cases that were watched, with 430 of those patients taking this formula. They were said to have mild COVID infection, but none of these patients developed serious disease. In the other group, the 291 cases in the control group, 6.8% did develop serious disease. So we have a fairly significant quote unquote prevention rate. So this study was done by, it hasn't been published yet, but we're, hopefully it'll be coming soon, by Dr. Tong Xiaolin, who is from, and his team from the Guanmen Chinese Medicine Hospital, along with several other hospitals and teams. So Dr. Tong is one of the 3 doctors on the steering committee, one of the 3 practitioners on the steering committee. So just to review that again quickly, just to see the distribution of the herbs that were given here. We got on the first night 27,000 bags of herbs prepared and given out on the next day. In total, there were approximately 700,000 doses of these herbs given out to approximately 50,000 patients in Wuhan. Okay, so mild and moderate cases. So there were 16 hospitals, temporary shelter hospitals in Wuhan, and one was exclusively managed by Chinese medicine team. So this slide really, I wanted to put it up there because I think it's important to look at Liu Qingquan's formula selection or recommendations for mild to moderate cases. And those who are familiar with Chinese medicine, specifically with the Shanghan tradition, Shanghan Lun tradition, and the Wenbing tradition, you'll see formulas from both traditions. And really what this is clearly characterizes is that Dr. Liu is not concerned about which tradition a formula comes from. He doesn't get bogged down in the dogma that can sometimes be perpetuated by certain factions within the profession, and rather he looks at formulas and patients and thinks about what he thinks will work best in the situation that he has in front of him. So I think that's really an important factor. This formula here is just one of the formulas that was given to mild and moderate cases. I'm not really going to discuss too much or really at all. I just want to put it up here as one of the primary OTC formulas that was used and distributed throughout Wuhan and other places in the country. This formula, however, I'll talk a little bit more about. This formula was developed for H1N1, and its actions are to coarse wind and diffuse the lung, clear heat, and resolve toxin. And so being developed for H1N1, this was considered a relatively well-known formula for similar types of diseases, and so was used here. And there is a study which I'm going to just quickly look at. So what you see here is this is an observational study of 80 cases of COVID-19 that was treated with this formula. And the results are based on the nucleic acid testing results. So what we see here, if you look at this highlighted boxes here, you see the treatment group had a negative 56, almost 57% of the treatment group had a negative test after 7 days, where the control group only had, the negative test was only a little more than 1 in 4. So this is a fairly significant improvement if we look at it from that perspective. Next, we're going to look at the Jiangxia Temporary Shelter Hospital. This was one of the primary shelter hospitals, and the one that Zhang Boli was a primary investigator in. So here we have, or is it Tong Xiaoling? I'm sorry, I'm a mistake. This was one of the major formulas that was used there. This is a modification of several classical formulas. And we also have a little bit of data for this one. This was another observational study. We had 280 patients in the hospital that were taking this formula, and 330 patients outside of the hospital that were not taking this medicine. And the patients that were taking the medicine and taking this herbal formula, 0% of them developed into serious disease, while the other, we had 9.7% develop into serious disease. So although this data is, you know, maybe a little bit flimsy in some ways, it gives us some sense that there is this potential for these herbs and these formulas to be helpful in these sort of epidemic situations. So then we're just going to turn to serious and critical cases, and I'm not going to go into too much details on these because, but I think it's important for people to understand that this Chinese medicine was used in this way. So here's Dr. Liu again, and so his primary medical training and practice is actually in ICU or in critical care units. So he has a lot of experience here. So this is a formula that was, in fact, just recently approved for use, and there's a good study from 2019 about this formula. So just have a look at this, and what you can see here pretty clearly. So we have the number of participants is relatively close, and we have a difference. So we have basically two groups of information that's important to us. We have the primary outcome in pneumonia, so it's improvement rate at day 8, and we have an average of 14.4% greater improvement when using this formula. And then the secondary outcome of 28-day mortality, this is even perhaps more important because we're talking about people dying. We had an 8.8% improvement in mortality on average when they were taking this injection. This is yet another injection. We don't have any data for, and yet another. And then this last one, I'm just going to mention briefly because this is some folks that are more familiar with Chinese medicine will recognize these are two very potent herbs. We're talking about ginseng and aconite here. And what I want to say about this is because this is really used in very sort of desperate situations, you might say. But also what I want to mention here is that Dr. Liu mentioned in his one of his interviews that what he found was when one of the main problems with people in the ICU units was blood oxygen problems. And so he was using ginseng in doses of 150 and sometimes even 300 grams per day to stabilize blood oxygen. He found it to be very significant. Unfortunately, we don't have any data. There's no observational studies that we're aware of, but I think that's an important note. So in the recovery stage, what's we can see here is this effort by the National Health Commission and the State Administration of Traditional Chinese Medicine that put out this document on February 22nd, so relatively early on. And so what it does is it looks at some basic things that practitioners around the country and lay people at home can do, and certain guidelines and how they can work towards recovering from being ill. And these apply to other kinds of illnesses. They're not strictly applied to COVID necessarily. So they had, you know, a couple of herbal prescriptions based on patterns such as qi vacuity or yin vacuity. You had moxa and acupuncture applications with modifications. You had food therapy, and you even had 6 different kinds of particular situations where there were additional food suggested for particular conditions. And these were mostly sort of what we would call like food-like herbs. There's a whole category of herbs that are readily available in grocery stores and markets throughout China. They're culturally appropriate. Many people know about them or perhaps even use some of them. These are things like poria, fuling, and baihe, lily bulb, and these other kinds of things that are, you know, readily available and everyone understands how to use. And there were other things like, you know, of course, Tai Chi and Qigong and sound therapy and even mental health type of things that were brought in. Finally, I just want to wrap it up by saying, just looking at this basic overview, and there were nearly 5,000 Chinese medical personnel sent to Wuhan, which represented about 13% of the total medical personnel in this emergency situation. These other statistics, you know, 91.5% of the, you know, total people diagnosed, 74,000 plus people diagnosed with coronavirus use some form of Chinese medicine, but we don't really have any specifics about that, so we don't really know exactly what that means. I mean, that could be anything from someone, you know, using a little moxibustion on, you know, stomach 36 or something to that effect, or, you know, could be all the way up to ICU. So it's a large range. So we don't really, that number's a little bit convoluted or perhaps inflated. And then finally, there were, you know, of all the total cases, 61,000 plus were in Hubei. And the utilization rate of Chinese medicine was over 90%. So again, this number, the same as the other numbers, a little inflated with respect to how much the Chinese medicine really was in play here and what sort of case the patient had, mild, asymptomatic even perhaps, etc. So, but these are the numbers we have, and that's what we have to work with. So I'm going to let Shelley finish up with the next part of our lecture. Thank you very much.
So what does all of this mean for the future of the development of the field of Chinese medicine, for possible new or revalorized uses of Chinese medicine, both in China and globally? In China, the medicine community is very optimistic that this will be a turning point, a very significant turning point for the medicine. So part of this comes from the fact that the government has given very serious, very prestigious documentation, but also recognition, acknowledgement of the leaders of the teams that were sent to Wuhan. So this is Zhang Guoli, and he was awarded an honor which means that he's a hero of the people. The infectious disease expert who was the leader and also the spokesperson during the whole epidemic, Zhong Nanshan, he was awarded the Medal of the Republic, the same honor that Tu Youyou was also given after she won the Nobel Prize. And this was the ceremony. You see the picture here with Xi Jinping. Zhang Guoli is a figure, he's a person that a lot of people find very likable because he just seems very human, real, and sincere, authentic. He writes poetry. Those of you that have seen our book have seen his poems. And this is a photo on the bottom. He was on a program called Face to Face when he first came back after his 100 days in Wuhan and his quarantine, and he was interviewed by a reporter in Tianjin, and he cried. And it says there, you know, this is the first time someone had asked me the question of what was it like when you first arrived in Wuhan? and he started crying because it was just a lot of chaos, people in the hallways, there were people collapsing, there were people that couldn't get the care they needed, whether they had COVID or not, and he was moved to tears. He also saw lots of medical personnel that were exhausted and really being pushed to their limits, and he's just showing his compassion here. So many people feel that he really is a hero of the people and very much deserves that epitaph. The right shows that he says, the main principle is that we should do whatever benefits patients. And according to his account and the accounts of others in the ICU, which you see in the top right, there was really very smooth cooperation between biomedical personnel and Chinese medicine personnel. There was a sense that if there's something you can do that I can't, then do it. And people worked together. And of course, the people that were actually working in the ICU, as Thomas just talked about, were experienced. Zhang Qingchen actually has a book, Liu Qingchen has a book where he talks about his 30 years of experience with acute diseases and critical diseases in the hospital. So these are people that are not new to this type of medicine. So many people were claiming back in the spring that this would be a massive turn, that this would bring about a new recognition, and people would suddenly start to change their misconceptions about Chinese medicine, that they would let go of the idea that it's only good for chronic diseases and see that it also can work for acute or serious diseases, for example, when people are in the ICU. And this seems to be what is actually happening. Xi Jinping wrote a really important article in Seeking Truth, where he says Chinese medicine needs to be included more substantially, more meaningfully in public health systems in the future, particularly for fighting infectious diseases. The state administration of TCM put forth this proposal that has 3 parts. That's on the next slide. Anyway, they're proposing quote unquote classical hospital wards. So we may think that you already have integrated medicine all over China, but there are still barriers. There's still legal and institutional barriers to Chinese medicine being included in certain wards in the hospital and for really taking the lead on cases for a particular patient. So there's a proposal for certain beds to be designated, and they give specifics in this proposal, which means that it's going to happen. When proposals come out with those kind of details, that means that it's going to be implemented. So they're going to have classical hospital wards for Chinese medicine. And flu season is coming up. The State Council has said Chinese medicine should be part of those efforts, that in addition to drugs and vaccines, Chinese medicine needs to be included in those. The Ministry of Education has said we need to not only create emergency medicine departments, some of you may have read Eric Karchmer's work about that, but also to really increase our level of literacy in the classical literature, because that was very much shown this time. People were not doing a sort of simplistic integrated medicine. They were really working with classical ideas, classical literature, and working very much within the tradition to a large extent. And the third prong would be to train people who can preserve what is authentic while innovating. That's one of the new slogans. And finally, a law has now been proposed. It's now in the period where people can give public comment to include Chinese medicine more substantially in the treatment of infectious diseases. So, I just want to close with Tong Xiaolin's quote, where he says that I think I've experienced this global pandemic, which is something that only occurs once every 100 years, and I can proudly say that our Chinese medicine passed this 100 years test. And he goes on and talks about how he thinks this will be the kind of change that is as thorough, as significant as changes in the past with Western medicine coming into China and the development of integrated medicine, or the division of Chinese medicine into departments, which was something that you didn't have before you had institutions. Doctors just treated whatever they either were specialists in naturally through their lineages, or they treated everything. So thank you very much, and we'll be available for questions.
Okay, well, thank you so much, Thomas and Shelley, for this really rich dive into both the social and the political context, and the in-depth look at the formulas. and their deployment in the hospitals. In the interest of time, I'm going to ask everyone to hold on to your questions, write them down, and what time we have left at the end we will use. But we have to turn now to Tawny Tidwell, who is speaking to us from the PhD Center for the Healthy Minds at the University of Madison, Wisconsin. And she has been engaged with a series of studies that have been taking place in New York, and I think elsewhere as well in North America, and looking at the use of Tibetan traditional recipes treating people in North America. So Tawny, well, would you like to take it away?
Thank you so much, Michael. I'm gonna go ahead and start the share. Great. So first of all, I'd just like to thank the organizers, International Association for the Study of Traditional Asian Medicine, IASTAM, as well as Dr. Angelica Messner, Michael Stanley Baker, Ronit Yolitalam for organizing this fantastic panel. I'm just delighted to be here, and it's so wonderful and exciting for me to hear about perspectives from Chinese medicine, because I get kind of sucked into the Tibetan medical world, and it's wonderful to see the intersections, and I'm really looking forward to fruitful discussion as well. And so today I'll be presenting first actually on the response in Tibet to the COVID-19 outbreak, the Tibetan regions of China, and looking at how that context of the response throughout Tibet set a specific initiative and drive that led us to looking at what we can do here in North America, US and Canada, and particularly what is our context for doing that kind of work, what has the response been, and what are the research possibilities as well. And then I'll talk about some of the preliminary aspects of what we call the North American COVID-19 Tibet Medicine Observational Study, NACMOS, some of its design and some of its preliminary cases. So, and part of this is also looking at how Tibetan medicine is coming from the periphery to the center and back out to the periphery, and how looking at these responses both in Tibet and in North America allows us to see some of that shifting from the historical perspective, but also contemporary perspective. And I just want to also thank IASTAM for supporting our research, and they have been kindly then matched also by Arizona Friends of Tibet in terms of funding. So thank you so much. So, days after news hit the Tibetan plateau of the novel coronavirus outbreak in Wuhan, provincial health bureaus and central Tibet medicine institutions across the region launched official protocols. You see this one from the Tibetan Autonomous Region, looking at prevention, treatment, and rehabilitation and preparation for cases of infected patients to come to their provinces, their counties, and their townships. You see here dietary and behavioral approaches, preventative medicine indications, treatment approaches, and also actual treatment methods. This was drawing from some of the standard formulas, a lot of the decoctions of Norbo Duntang, Chultang, some of the older formulas of Lo Gyuma, Tsoa Nyanga, Lotse Kunsel, Datsi Marpo, the Mangdro precious pills. And then we also see an innovation of looking at a lot of the textual support for drawing back from some of the older texts of new innovations in terms of menjor and medicine compounding. We see here Tangchin Geba, Tangchin 8, and so Chuksum, so 13. And this was looking at how to prepare these regions for the incoming infected patients coming to their region. Senior physicians also published statements instructing junior colleagues on treatment protocols for this novel disease, looking at aspects of the Mamansawa, the unripened fevers, when it should transition to the Getse or the Dongtse, the expanded fever or the empty fever, how to support the immune system, lower inflammation, improve lung function, support digestive capacity, and improve overall physical strength. This was again looking at the legacy within the text of this time when epidemics were predicted to come online during this degenerate age, looking at specific aspects of these diseases that were predicted and nuances that were new or novel in terms of the medicine compounding that were expected to be needed during this time. And this comes from this rich textual foundation for this class of epidemic level infectious diseases we call Nierim that were predicted in these early texts. Senior physicians also permeated the social media with their public health education presentations, including excerpts drawing on root and commentarial texts. You see them in these little WeChat images, and looking at how these passages from the text within the traditional Tibetan medical tradition could be linked with public health outcomes that were discussed in these early texts. So we see these from texts coming from as early as the 12th century and bringing in some of the imagery as well, looking at hygiene practices, social distancing guidelines, protective behaviors of covering one's mouth, not partaking in potentially contaminated foods or places of exposure, aspects of mantra, and also various aspects of mental visualizations and patterning as well. And combining those recommendations and quotes with this modern public health education style, visualized graphics, which I think you guys saw as well with Shelley Oak's presentation and Thomas Garon's presentation as well. So very similar in this framework, but also using the drawings and images that fuse this Buddhist framework with these health guidelines. Professors and clinicians gave interviews and lectures describing how this disease relates to that which is described in the text, as well as how the symptomology that had become public at that point to standard nosologies of flu-like viruses, heat and fever conditions, and so forth. In these professional and public talks, including those by Harvard alumnus Yanga, and here the UCLA public health graduate, Dr. Kunshi Gansen, professor of Qinghai University Tibetan Medical College, it became apparent that the emergence of SARS-CoV-2 presented not only a major national health crisis, but simultaneously opened up the possibilities for a new emerging public face of Sowa Rigpa, what Tibetan medicine is called in Tibetan, the science of healing. And this is a stark contrast to decades earlier when you didn't have many Tibetan physicians cross-trained in biomedical discourse or clinical practice or even public health, and you certainly didn't have a national government open to the contributions offered by this traditional medical system. So I argue that COVID-19 has provided an opportunity for Tibetan physicians in Tibet to come from the periphery, so to speak, to the center of national discourse in China to showcase the significant developments that have been achieved in restoring the educational, clinical, and professional spheres of the Tibetan medical field. It has also provided an opportunity to showcase their achievements of this repaired tradition, a tradition that has now regenerated through significant hard work, redevelopment over the last several decades, by offering concrete pharmaceutical contributions to care and integrative medical paradigms for supportive recoveries. Now, China officially classifies Tibetan medicine as a traditional Chinese medicine under this contemporary umbrella term, encompassing all its ethnic medical traditions. So this policy risks absorbing Sowa Rigpa into this larger category, making it invisible to the greater public. Yet Tibetan physicians are collectively transcending this limitation and skillfully navigating the restrictions and requirements, and sometimes these requirements being unspoken and merely inferred, of participating in this paradigm, a paradigm in which non-participation would effectively amount to one's removal from existence or full annihilation, so to speak. And to avoid this peril and transcend the limitations, they are building status for their tradition in this context of major public health concerns in a global era. So COVID-19's pandemic provides this critical window to track Sowa Rigpa's scope and impact in China, at least in the Tibetan regions at this time. And as their expertise flooded the virtual landscape in early January, Tibetan medical institutions also provided physical relief, workers and large supplies of respiratory and infectious diseases, medicine from the traditional Tibetan medical background to affected areas in mainland China, including Wuhan. These included the externally worn sachets, the Nakbo Gujor, or the 9-compound black pill, traditionally described for its protective qualities of epidemics. These were also sent to regions throughout mainland China affected by the virus in Hubei, and the outbreak. And these shipments launched directly from Lhasa, Mensikang, Qinghai Provincial Tibet Medical Hospital, and various prefectures, counties, private producers, and so forth. And although government regulations limited acceptable relief donations to formulas meeting the National Good Manufacturing Practice, GMP standards, contributions still amassed a net worth of tens of millions of renminbi. Likewise, restrictions on traditional medicine permitted in biomedical institutional treatments also constrained formulas to just these mild cases. Chitin, China's biggest Tibetan pharmaceutical producer, also sent its licensed formulas. It has some of the most numerous licensed formulas to be used in biomedical facilities. They sent them to Wuhan and to a lot of its Gansu hospitals as well. And so it's important to note here that if these traditional medical formulas are to be used in biomedical facilities, even facilities that have a traditional bend or are exclusively traditional medical institutions, say Chinese medical institutions, they still need that national or provincial licensure to be able to be used and implemented. And there's a rigorous process for formulas to actually be approved for use. So though Lhasa's first reported case was not until January 25th, by February 25th, Tibetan regions had significant transmission, with the greatest concentration in Ganse prefecture in its eastern Dao County, particularly. And this is here, the team on the left side doing management and preparation, and this is here on the right side in actual care. Prominent private physician Jigme Phuntsok contributed 500,000 renminbi, almost $70,000 worth of one of his national certified formulas, Tatsi Marpo, Red Tatsi, which is known for fighting respiratory and brain infection. And here it's interesting to note that even in the early text here, a recognition of the role of neuroinflammation or inflammation of the central nervous system as an important part of the pathology of this disease, as well as systemic inflammation in the form of fevers. Even in areas with no reported cases, physicians donated protection substances, such as we see here, the Nakpo Gujo again, as well as what Rimsung, these epidemic protector amulets to their local communities, simultaneously providing virus education outreach and encouraging stringent health protection measures. And despite some criticism within the field, such as by Southwest Minzu University Professor Emeritus Thupten Phuntsok, accusing Tibetan physicians of exploiting the crisis to make profit on amulets and preventative substances, and claiming that mantras are meaningless during epidemics, which I find quite interesting since our center looks at the effects on the immune system specifically of contemplative practices that originated and propagated throughout Tibet. The provincial and township level physicians and institutions deliberately continued to their efforts and donated time and resources. Several hospitals even provided free care to confirm cases, and whether Thupten Phuntsok's comments incited greater charity is difficult to determine, but regardless, generosity unfolded substantially. So the Tibetan medicine, and this is here, Dr. Danzin, even from Goluk, a remote area in Darlak County of Qinghai Province, the Vajra armor externally worn, internally taken, and regional or area protection donations that were amassed and instructed to local physicians and then distributed more extensively. So the Tibetan medicine industry has grown over the last few decades, reaching a $1 billion production by 2018. This is work that we did with the Austrian Academy of Sciences, led by Dr. Stefan Kloos, Callum Blakey, Harila Madhavan, Dr. Mengitsoma, and myself, looking at the scope and extent of the Tibetan medical industry. And this richness of tradition, the proficiency and rigor put forth in this contemporary context could not be demonstrated decades earlier, when Tibet medicine was under heavy scrutiny from the central Chinese government to appear biomedical and non-religious. After the initial democratic reforms from 1959 to 62 and the Cultural Revolution 66 to 76, the period following Mao's death led to cautious expansion and legitimization efforts among Tibetan physicians. So Rigpa institutions stripped any Buddhist or Tibetan cultural references from their medical curriculum and instead framed medical content in terms of biomedical terms. In the post-reform era, state funding transformed Tibetan medical institutions into partial replicas of their biomedical counterparts. For compliance, Tibetan physicians can consciously reframe disease causation explanations in explicitly biomedical terms. This can be seen perhaps best by the publication, The New Dawn, Gyaring Tsawa, by Dr. Samten, which emphasizes a new nosology highly conversant with and informed by biomedical paradigms. So recent decades, however, have seen this new wave of central government support for ethnic minority medical traditions. We see this in Article 14 of the People's Republic of China statute for use of traditional Chinese medicine pharmaceutical compounds. We see funding coming from the national level, distributed and implemented throughout Qinghai province and other regions of Tibetan populations. And that this is looking at explicit legislation supporting their role in combating common diseases, chronic conditions, and epidemics. Xi Jinping's advocacy for traditional culture and integration of ancient Chinese philosophy has created a rhetorical distance to a time when Mao attacked Confucian ideas, erasing them with revolutionary fervor. Today, Nostalgic for tradition and eager for rehabilitation, public discourse has situated Tibetan medicine in a politically favorable climate to regenerate tradition and expand medical practice and scope, though still forcing physicians to walk a fine line with religious practice. By 2019, Qinghai Province had procured funds, built and staffed Sowa Rigpa facilities at every administrative level, such that access to healthcare provided by Tibet medical institutions now outnumbers that of biomedical clinics across the province. And this was told to me by Qinghai Provincial Health Bureau Ethnic Traditional Medicine Division Director, Dr. Dotsun Tundup, whose job it is to go and look at all these clinics, departments, and hospitals. So before 1950, Sowa Rigpa was virtually the only form of healthcare on the Tibetan plateau, and redeveloping Sowa Rigpa so that it features centrally as the primary healthcare system in Tibet, even expanding it beyond its historical reach, is eagerly welcomed by Tibetan physicians and the communities they serve. This represents a distinct departure from decades of historical relegation of Tibet medicine to inferior status and widespread Tibetan distrust of Chinese institutions and physicians. This comes from a system that was prominently corrupt throughout that time and which disenfranchised those who were not native Chinese speakers or even a part of the Han majority. This proliferation of Tibet medical institutions now provides space for cultural expression, addressing community health needs and cultural sensitivity in treatment. A crisis of confidence that Sienna Craig had coined decades prior when Tibetan physicians questioned their competence alongside biomedical peers has segued into engagement where today in the PRC, most Tibetan medical and education bodies work in tandem or full integration with biomedical colleagues through partnerships and cross-training. Many Tibetan physicians gain insight into the weaknesses as well as strengths of biomedicine and are able to emphasize Sowa Rigpa's unique contributions, which I'm calling a rehabilitation of confidence. Neuroscience research has generated insights on health benefits related to practices of Tibetan Buddhist expert meditators. This is where much of my current work is based, where the cognitive neuroscience and psychoneuroimmunological outcomes of contemplative interventions are measured and studied, including using Tibetan practitioners or long-term meditators, such as Mingyur Rinpoche, have been studied in our lab, where the research of benefits of long-term practice have become well known. Alongside China's Buddhist revival, with mainland Chinese also seeking Tibetan Buddhist teachers, who you can read more about this through Kat Hardy's work on the frontier regions of Tibet and a lot of the Chinese students of Tibetan Buddhist masters coming here. These influences give Tibet medical professionals confidence to more openly discuss Buddhist practices in relation to medicine, and physicians recommending visualizations, compassion meditations, and even certain practices to mainland Chinese patients. Such methods would not have been openly discussed or advised decades ago, even though practices are often more recognized and celebrated in terms of their effects here in North America. As news of containment in Wuhan spread, Qinghai Provincial Tibet Medical Hospital reported on Xining's recovered cases accepted for post-recovery care at their hospital under their developed protocols. Dawao County reports also merged on cases treated successfully with integrated biomedical Tibetan medical care and making their physicians cultural heroes. And so here we see the cases that came into Dawao County over the course of the initial part of the outbreak and the breakdown in terms of patients. They only had 73 confirmed cases, but all treated with a combined Tibetan medical and biomedical protocol. These are some of the statistics, well, the data from the comorbidities that came into Dawao County and the various medicines that were primarily used for treating these cases. So it's important to recognize the bureaucratic context in which Tibetan physicians were operating in their own Tibetan regions in China, and the distinct opportunity that that context then highlights that we have here in North America. So any COVID-19 patient in Tibetan regions in China has to be admitted to hospitals in which biomedical treatment, these are severe cases, was prioritized. And even if traditional medicine was permitted, was a sideline therapy. Each medical facility has various medicines that are permitted for use by that facility, even in these Tibetan regions, and will have permissions to use those pharmaceuticals primarily. So the traditional medical pharmaceuticals that are permitted must go through these provincial national licensures, even in their regions. And the traditional medicines used in these traditional Tibetan medical facilities also go through a permitting process by which they can only be used at that facility for which they have permission. So one producer cannot necessarily distribute its product widely to many different medical centers without the medical center having specific permission to use that formula. So this means that many hospitals use formulas that are made in-house, which come with some heterogeneity in formulations, sourcing of materials, and certainly on a research front, a lot of challenges. So I'm gonna go ahead and stop the share here just for a minute. Oh, maybe I'll just keep it up. So news circulated that only 1 of 1,000 Tibetan students in Wuhan had confirmed viral contraction. Many Tibetans had attributed this to the news of precious pills, mani rilpu, or blessing pills, and other Tibetan medical preventative measures. So precious pills are organometallic compounds made over 40 days of preparation that include up to 140 different minerals, metals, and organic compounds that are primarily used for chronic intractable conditions, however now are widely used for a wide variety of applications due to the benefits ascribed to them, many of those studies done in China. In India as well, now precious pills have become a frontline prescription for both preventative as well as treatment courses of COVID-19, even if they have not featured centrally in the treatment courses used here in North America. So among these reports, Zhong Nanshan, China's chief coronavirus expert, announced that the National COVID-19 Research Committee's interest in Tibet medical approaches to mild cases due to the preliminary efficacy evidence and potential insights from a history in high altitude hypoxic environments. And one of the particular herbs of interest was a variation of the ma huang, the tsedum, or the phedra from the high altitude regions. Zhong Nanshan also announced a research collaboration with Tibetan, the Tibetan largest Tibetan pharmaceutical company in China, launching a 40-subject clinical trial in Wuhan using 3 of Tibetan's national approved formulas, Trutang, Logyuma, and Mangjor. Data collection has presumably completed, but we don't have any official publications out yet, but a preliminary auxiliary report recommends adjunct use of Tibetan therapies in many of these biomedical hospitals to reduce mortalities as of March 2020 in the Tibetan regions. So local plateau research institutions also receive national funds in millions of renminbi to expand related studies, particularly related to the Nakpo Gujar pill. And Tibetan physicians have skillfully navigated the challenges while also mobilizing in this novel crisis context, the demonstration of an awakening tradition coming from the periphery to a more central location. So due to the limitations, and here's the crew from the Dao County. These are the head physician from Ganzi Prefecture, as well as Dao County themselves. And this is from some of the presentations given by Dr. Nya Gyaltsen as he was presenting his research, how the original COVID cases came into Dao County, the tracing efforts of confirmed cases, the initial cases that spread primarily to local families and then to the community at large. So due to the limitations of not being able to treat patients exclusively with Tibetan medicine in Tibet, many of our colleagues in Tibet contacted us here in North America, urging a full-scale Tibet medicine study as COVID-19 cases grew. What many of them did not know is that we in North America operate with our own set of restrictions to caring for patients in biomedical contexts. Most Tibetan physicians operate in small private clinics or out of their homes, and since Tibetan medicine does not have a licensure established in North America yet, many operate under acupuncture licenses as herbalists, functional medicine practitioners, or simply under the provision of state-based Health Freedom Acts, the provisions of which differ state by state. Likewise, the capacity to launch a full-scale randomized control trial here in North America first requires preliminary evidence from pilot studies to demonstrate results convincing enough to warrant a full-scale RCT in the US with approved formulas through the FDA gaining an investigatory new drug license that is quite difficult for formulations that have up to 140 ingredients, tens of thousands of compounds in themselves that are regularly used for our frontline treatments for these cases. My pharmacology colleague, Dr. Jim Nettles, and I addressed this challenge in drug discovery and the need for new methods to focus on network pharmacology and systems biology to fully appreciate the synergy by design pharmacology that guides Tibetan medicine compounding in Tibetan medicine, in which separating the component ingredient parts would merely demonstrate high toxicity in some, varying activities and neutralities in others, but not what happens when the sum of the parts are assessed for the synergistic effect. This is a lesson we learned in biomedicine with the development of HIV cocktails, where an opportunity to reduce resistance to the drug and mutation of the virus or pathogen is heightened by formulas that have pleiotropic signatures. This is work done by Herbert Schwabel and Jan van der Velk, in which we look at the role of Tibetan medicine formulas on acting on multiple biological targets instead of a narrow range, more susceptible to developing selective resistance. So my colleagues at the American Tibetan Medical Association, as well as Dr. Tenzin Namdul, former research director of Mensikang in India, Dr. Sienna Craig at Dartmouth College, as well as many others of the American Tibetan Medical Association throughout North America, came together and decided that we have an opportunity to track the cases that are treated by our Tibetan medical community in North America exclusively by Tibetan medicine. We recruited 20 of our participating Tibetan physicians from New York, Toronto, Minneapolis, Washington, D.C., San Diego, Madison, Chicago, San Francisco, and Boston. Have student volunteers from UT Texas, from Austin, UC Davis, and so forth. And we have identified 200 patient cases so far. So at the early state of the outbreak, many cities did not have adequate testing, and many moderate to even fairly severe cases were not admitted to the hospital. So we had quite a bit of heterogeneous data, but some with very significant outcomes. One such case has become well known in the Tibetan community, even circulating widely with Tibet itself, and I'll share that case now. This was shared by social media by a close female relative of the patient. She describes her cousin as a 54-year-old care worker in an elderly care home, in which she was working with one staff member and 2 residents, 3 people in total that had tested positive for COVID-19. Both residents were her assignments, and after 1 week of care, her body started showing symptoms. The symptoms included a fever, a dry cough, sore throat. She did a nasopharyngeal swab test, and the clinic had told her to quarantine for 2 weeks. Soon after that, she had noticed that the fever had disappeared, but new symptoms had showed up. She had shivering and body aches and pain, and extreme pain coming through her shoulders to her waistline and across her back. She described the pain as unbearable. She couldn't sleep, lie down, sit, or stand. And on day 5, decided to go into the emergency room to see if perhaps that this pain could have been from a UTI or a kidney problem. They took her blood and urine tests, and while waiting for those reports, decided to go ahead and do a CT scan to rule out serious kidney disease. And again, she was told to wait for her report. But soon after her CT scan came back, both lungs had been penetrated by the virus, and the physician said they can't do anything, for her to go home and rest, and that if she has any changes of shortness of breath, she should come back to the ER. She says that she arrived home at 3 a.m. and by 4 a.m. she started going into severe pain as well and shortness of breath, but she decided to stay home. The next day, she looked for a phone number for the Tibetan physician locally in Toronto and contacted him. He prescribed her a Tong decoction pill or decoction formula and Kyunga, which is an anti-inflammatory in the tradition. And she then took those, slept, and after an hour had gone into full drenched sweats. This is what we call the dutang, when we're actually cleansing the heat and fever. And her symptoms had vanished by 3 days later after going on to a successive regimen of 4 other formulas. So after taking these formulas, her husband, who had also contracted the virus when he had driven her to the ER, and also her mother and father came on to get COVID-19 and also be treated by Dr. Ketam Gyamtso in Toronto. This case then fled into Tibet and really gained support for having a lot more of our Tibetan physicians participated in the research to see that we had an opportunity to look at some of the cases that we are seeing here in the US be treated by Tibetan medicine. So one of the benefits that we also have is, so Dr. Sienna Craig, who has launched the Voices of the Himalayas project with Endangered Language Alliance, has noted that many of our Tibetan communities are at the epicenter of the outbreak, that such as in the Queens neighborhoods of New York, that they are in many ways some of the frontline healthcare workers. So in Toronto and Minneapolis as well, we see that they're often the ones that are in COVID ICU wards, that the ones that are frontline on the exposure. And so many of these cases would be nurses that were treating COVID patients that would come home and then infect their families. So a lot of our data also comes from this heterogeneous context in which not necessarily everyone was treated was tested. And so we're looking at how to get some of our antibody follow-up testing to solidify some of the data that we've been able to collect so far as well. So the North American COVID-19 Tibet Medicine Observation Study that we've looked at, we first helped a lot of our physicians understand what the research context is in the US, so different approaches to research and helping them understand what we were doing as a team, helping them to understand the context for doing research in the US, that we were focusing on observational case series, helping them to understand what was rigorous data collection, what was important in terms of the documentation of their cases, because again, their context is working out of homes or in private clinics where they're not necessarily exposed to the rigorous diagnostics that would allow us to gather a lot of this data. So I'm going to end there and turn it to questions, but we have now data coming back from our team, and we're hoping to have all of our cases returned by the end of December. So I'm looking forward to discussion. Thank you so much.
Great, thank you so much. This is an incredible, fascinating, and very rich and broad presentation of many changes, actually, in terms of the depth of scholarship that we know of the situation of what's happening in Tibet. And also, for what's new for me, this expansion of clinical access across the Tibetan Plateau. I think it's really important element to the changing dynamics of this story. And as well, I think the issues that you bring of the different diagnostic tools that you're able to use and the categories that you're using, being able to communicate in North America, are very important elements of these of the ongoing integration and conversation across disciplines that IASTAM really aims to further. In the interest of time, I want to invite everybody to hold on to your questions. Feel free to email them to me, actually, if you like, I should probably best email them to me, just mstanleybaker, no hyphen, @gmail, and I will collect them as we go through, since we don't have a text option. And because I'd like to hand over at this point to Professor Marta Hansen from Johns Hopkins, who's going to be presenting on this transition from sick man of Asia, this model that we're so familiar with from the 19th century, to sick Uncle Sam, in the case of traditional Chinese medicine and COVID-19. So I'll hand the floor to you, Marta.
Thank you so much, Michael. I think I'm going to end up talking right up to the time that we are that's designated for this presentation. Okay, so I had quite a structure to go through, and forgive me for maybe speaking quickly to get through it. I was first inspired to write in response to COVID-19 during a presentation of the American Association of the History of Medicine. We went quickly online. I was on the board and created this program. The last virtual panel, our colleague Ruth Rogoski spoke, and she made 2 points that were really important at the time. One, of course, that you have to understand the response to COVID-19 out of this broader historical context of China having to deal with the epidemics on the back of Western imperialism, but also that from the present perspective from East Asia, there's been a major reversal from the sick man of Asia to sick Uncle Sam. And so I asked Ruth if I could run with that idea, because I had just at the same time been asked to give a perspective piece for this journal. You'll see it noted on the bottom there, the old and new sick men, which I will actually sum up now for you. I wrote this most of summer, so starting in May, finished it in June. July was published it was published in September. So this is the structure that I had set up, and you get an idea of what the sick man of metaphor meant and was, as Michael has just introduced. What is this East-West role reversal then, and some background to how that happened and what it looks like now on the ground. And then what is a discourse of weakness, and why I argue it was quite powerful for China. And I think that we should take on the sick Uncle Sam moniker. And from that point, you can actually start to make a diagnosis with the sick role and take some responses and therapy to that. of course, we're not going to be able to do that under the current regime. So that was the basis of that article I wrote. And then I have a piece on how TCM for SARS and for COVID-19 is really very different. So I've structured this talk this way. I'm going to work quickly through the first three parts, which are actually published, and I amplify some things in these slides, and then get to the last part where I think that we're operating in a very different context. There are lots of continuities which I'll bring out, but I think just the fact that we're having an IASTAM webinar right now, and the research that and the publications that Shelley and Thomas have done, and what we just heard, really make this situation in terms of our understanding of what's going on the ground and what is actually going on the ground really different. So first part, there's legacies of late Qing China that relate to how China became called the sick man of the Far East. So I summarized that. They were having to deal with the combined burdens of war, foreign incursions, epidemic diseases, famine, etc. And so this earlier trope of the sick man of Europe, which had been originally applied to the Ottoman Empire in this particular context, just to bring everybody up to speed on its history, comes out of allegedly Nicholas I referring to the Ottoman Empire as a man that was gravely ill, right? And then the British ambassador responds with a different perspective. Well, those countries that are in better health should actually take care of the sick and feeble. So that was written at the time, the origins of this kind of trope. And a lot of people don't immediately go to how it gets applied to China, but I found that the New York Times refers to the United States actually quite soon after the Crimean War and after it was applied to Turkey, in terms of something we may find very familiar from the US perspective of gridlock in Congress and how to deal with the Mexico question, and essentially losing that battle. So I wanted to highlight that it does get used to define the failures of US governance, and it's kind of prescient that we see the sick man being applied to our present. So sick man of Europe, here's a cartoon of the Sultan at the time in front of a poster announcing the reorganization of the Ottoman Empire. And we see that actually Russia, France, and England are going to be the directors of this new reorganization, and obviously his sword pointing downward, symbolizing his impotence in light of these transformation. North China Herald in 1896 actually uses it to criticize China's governance. And here's an example of the way it was used to criticize Chinese education, its justice system, corrupt officials, etc. And within 2 years, you see actually the Abdul, as we saw before, in the same garb, cheerily confronting representative here of the Emperor of China, saying, "Oh, you should going to pieces, old man, nonsense. All you want is a dose of concert of Europe. Why look at me?" And so he's accepted that Europe has basically reorganized Turkey, and he's suggesting the same for Qing China. We also see it being used in another New York Times article, in this case directly related to the Portsmouth Treaty that helped conclude the Russo-Japanese War. And John Hay was the Secretary of State at the time, credited with guarding some of Chinese territorial sovereignty in that negotiation. That just gives you a little sense of its history at that time. Now, moving to the second part of my article, which is on the East-West role reversal. We have, I think, to understand it very much in terms of East Asian experience with the coronavirus. So, of course, the SARS experience was central, and MERS as well in South Korea for the East Asian countries at the time. Having this experience didn't stop their pandemic response systems that they collectively had to develop in response to SARS in their region. But I also want to give it a larger historical perspective in terms of 19th century pandemics that ran through the region as well, both cholera pandemics and what we call the third plague pandemic, coming out of Yunnan and then erupting in Hong Kong on the international stage, and then in Manchuria, and then the most dramatic one, even more deaths of Manchurian pneumonic plague epidemic with over 60,000 dying. So that 19th and 20th century experience, I think, is really important for understanding East Asian nation states and their political systems, the medical governments having to be fortified or developed in terms of responding to this wars, epidemics, and national humiliations. So this is one of my main arguments, that history of epidemics is absolutely central to understanding East Asian nation states developments. And it comes out of work with Vygotsky, of course, and also Carol Benedict, and synthesized by Robert Peckham most recently in his book on epidemics in modern Asia. So despite different languages, cultures, national histories, healthcare systems, which all of us will understand are very different, I think these twin legacies, the 19th and 20th century epidemics and the response to 2002-3, the newly emergent epidemic of the 21st century, SARS, helps explain the collective East Asian success in controlling COVID-19 today. Of course, there's lots of differentiation, which I want to highlight this journalist who summarized them in a two-part report for Asia Times. Really great review. And I just sum up how he refers to the East and the West, and saying why East Asia collectively responded better than the European Union or the United States. And he breaks it down into different dimensions. And I am not going to go into the specifics. Honestly, I think it's going to be in the next decade before we fully parse out the regional differences and get down, well, get on the other side of this pandemic and do the historical, sociological, anthropological, et cetera, work to really wrap our heads around the complexity of it. But I think this is a really good first stage, and I wanted to highlight the different ways that he broke down the distinctions in the region and compare them with the West. Now, one of the things he did do in the conclusion is he argued that there was a pervasive Western sense of cultural superiority that contributed to arrogance toward Eastern models, which I think we can all agree is behind the response to Chinese medicine and Tibetan medicine being used and the skepticism toward it, and also ignorance. I think that's an important point as well of East Asian history and the region's very modern healthcare systems. I developed a course on history of public health in East Asia in large part at Hopkins because they don't ever talk about public health beyond the Anglo-American system or what they call the third world system, and then you get into the international global health systems that are developed in responding to epidemics in everywhere in the world, but they leave out East Asia. So there's that point of his article that I completely agree with, but it's very curious that he completely neglected national policies in East Asia toward traditional medical systems. So of course, South Korea is a very separate discipline from biomedicine, and it wasn't top-down supported, but people in that community were treating patients COVID, and certainly on prevention, they were a part of that effort. You had Kampo pharmaceuticals covered by insurance, and of course, Japanese government wasn't embracing these for treating COVID, but it was nevertheless part of clinics, and patients were using them. Taiwan, there's some evidence as well, and certainly we have, as we've already seen with Shelley and Thomas' presentation, China was promoting Chinese medicine, but it's still hierarchically subordinate to Western medicine. It's still more widely instituted than anywhere else in East Asia. And I think that's an important point to make. And one of the things I wanted to make here is that in the case of TCM and SARS, I wrote this article, and I can't assume that everybody listening today has read it or knows what my main arguments were. So I'm not going to read what I said. I just want to sum up the main points I said in this article and articulated then Michael gestured to it in the very beginning. But one of the main points I want to make is, in terms of continuity with the present, we still have the problem of media blindfolds. So the distinction I made is that there's some things we don't see, we have conceptual blind spots, but the media blindfolds have to do with when the media just refuses to acknowledge what is actually happening on the ground because of prejudices and a biomedical dominance. So one of the things I tried to correct in this article is an understanding of why Chinese medicine was an integral part of the response to SARS more than any other of the nations in that region. And this is, one of my attempts to address that lack of historical understanding. We go back to the Summit article. And what I try to do is to really understand what it is that the Chinese physicians are doing. Like, how are they thinking when they administered these integrated treatments from a historical perspective, sociologically and politically? So I think in this situation with COVID, of course, Shelley and Thomas are letting us know and putting it in English how these practitioners are thinking about their pharmaceutical interventions, which was not the case for TCM and SARS. I was tracking everything in Chinese at the time, but now we have a translation into English, which I think greatly helps us understand that phenomenon and more on its own terms. And the big point I make in my book that I published just a year after this article is that the categories that they use at the time, in this case, the one I focus on is Wenbing, are meaningful because they legitimate therapeutic strategies that otherwise don't have a larger conceptual infrastructure to delegate what therapy to use for what. And so those persistence of these traditional disease categories is very important to understand as a form of resistance to the narrowing of therapeutic possibilities when you only use biomedical categories. So I just end with that. And obviously major East-West role reversal acknowledged in the United States and by the rest of the world. Big part of that is that we do not have a 4-step public health infrastructure set up in the way that East Asian states mostly have at this point. Certainly China has, and there's lots of complexity behind why that's the case. Just to give a sense of how the reverse was in numbers, this is the Hopkins map, which I look at practically every day, and we're well over 200,000 deaths now. And just to give some historical context to what that means in terms of US war fatalities, it's greater than these 3 wars put together. And I think that we're moving toward the numbers in the 1918 influenza pandemic. So this is just to give you a sense, that historical context, and it's spread around the world. And what I find really remarkable in terms of comparing COVID-19 to the 1918 influenza pandemic is that the numbers, the accounting of the death across the globe, estimates are from the conservative 50 million to upwards 100 million. So why is such a gap? And why is it called the forgotten epidemic? Well, part of it is that the state and medical infrastructures just couldn't deal, with accounting for the dead when they were stretched to capacity to care for the sick. And now we're in a situation where governments are just, especially the US government, don't want that kind of transparency because it's not good for their political outcomes. And that's a very scary but real place that we are now. And people are traumatized by the hit of World War I and losing their loved ones. I even have a personal story of my grandmother being blamed for the death of her aunt. She was only 7 years old, and her uncle just leaving the family completely. And she never wrote about this in her memoirs. She only admitted this like the last year before she died in 99. And that gives you just a sense of like the reason why it was forgotten in this one particular small anecdote of my family, and amplify that up globally. You get a sense of what that trauma was like then. And I think that we're dealing with a comparable trauma and a comparable, I hope, but possibility of forgetting, which I'm trying my best to not have happen. So what do we mean by discourses of weaknesses? So find these really useful operative monikers. So Uncle Sam works because it, represents something really complex in a simple way, that is the US government. And the sick label, of course, offers the possibility of diagnosis once the role is accepted. And I was really surprised to find that the Uncle Sam, sick Uncle Sam metaphor has an old legacy, even predating the sick man of Europe metaphor. So this is an editorial cartoon diagnosing basically the ills of Jackson's dealing of the economic recession in 1837 and reliance on species instead of on paper money. And here we have the solution being basically bonds and post notes. You can see how the medical metaphor operates in this context. So sick Uncle Sam today has purchased and predates COVID-19. We see somebody using it to talk about failures in foreign policy, see someone else using it in talks about Washington gridlock, which we also saw in the 1816 New York's editorial. And we see The Economist using it in terms of the coronavirus in mid-March. So the sick man of Asia, of course, it was used to pejoratively position China as inferior to its East Asian neighbors, as well as European counterparts. But what I think is important to acknowledge is that it's a powerful discourse of weakness in that it included concepts of national salvation, saving the country by science, etc., that then links it with social Darwinist interpretation, was motivating for the Chinese government to pursue long-term policies to regain its national strength and with the overall goal of rising above all natures on the global stage. And I think that we see this echo very clear in the conclusion of Shelley and Thomas's presentation about how they're presenting their success with controlling COVID-19 as a illustration of their representation and of their own governmental success. Now, by contrast, we have Uncle Sam here rendered as an invalid by the misrule of Trump, virus spreading novel Corona King. And I think this was drawn by my partner in March. I published this, end of August, early September, included this editorial cartoon. And of course, this was rather prescient of the Trumps actually contracting COVID-19. So I concluded that article saying that a regime change would be needed for Uncle Sam to acknowledge being sick, accept that diagnose illnesses and comorbidities, and effectively mobilize the wider range of treatments available from East Asian experiences, historically, models, it's more broadly in healthcare systems, and even their medicines, of which obviously he and more broadly the West currently scorns, you could say. So now just quickly, I want to wrap this up. I want to say the situation with TCM and COVID-19, the representation in the press in East Asian language, I was interviewed for this, is very different, very positive, as we already heard. The response in the West is predictably very negative and skeptical. And just to sum up, Orthodox medicine is considered to have higher scientific status or standards for evaluation. They argue that Chinese pharmaceutical companies are taking advantage of people. We also saw this with TCM and SARS press. And even further, Breitbart, which we have to look at very critically, argues that it's Chinese Communist parties promoting it, not just as form of propaganda, but in terms of enriching itself. So that's where the press comes from. That's a very negative coverage, which is comparable to what we found for SARS, and very typical attitudes, I would say, that go back even to a time when Western medicine had no cures. Okay, so I wanted to present that context of the third plague pandemic on Chinese soil. And there was Chinese who were very skeptical of the Western approach. So that is a broader historical context. This is a kind of understandable why they have this kind of skepticism, which has been raised before. And one thing that I offer is the concept of medical bilingualism, which we can talk about. I'm going to wrap this up. And this is the idea that Chinese medical practitioners are toggling between actually incommensurable systems, between Western biomedicine and Chinese traditional medicine. And I like this illustration because it really displays that you can't see the duck on the left side or and the rabbit at the same time. You really have to move cognitively from one to the other in your mind to see the duck and the rabbit, but you can't see them at the same time. So I argue that there is a form of medical bilingualism that Tu Youyou came out of. But she was really given this Nobel Prize because she transformed the drug into an active artemisinin in using organic chemistry. But what I wanted to argue in that article where I introduced the medical bilingualism concept is that she was operating within a biomedical and traditional Chinese medicine institution in Beijing. Well, actually, Shelley's situated right now. So I think that we see this medical bilingualism in the case of SARS and COVID-19. And I just give some examples that have already been introduced by Thomas, actually, some of them. And we also see really major differences, however, in terms of the percentages, which was introduced before, of what is reported in terms of Chinese medicine use in China. Also, really major difference in that herbal medicines are being sent outside of mainland China. Of course, there's a big political backlash, or at least critical one, from the Western press, and that it's globally spread. That's far beyond SARS. That's really different. And then we see failures of U.S. and European and other nations to deal with it. And as we saw in the previous presentation at Tony's, that not just Chinese medicine, but also Tibetan medicine are being used for acute infectious disease. So this is where I want to sum up that this is a really different situation. And other things that make it really different is that people are responding. That we as academics in our different fields are responding immediately. So this is a really excellent review of the global politics of traditional medicine that my colleague Helen Tilley published in May. And she really argues for the concept of polyglot therapeutics. So I highly recommend people read that if they haven't, or include it on your syllabi. I really like it. And just to conclude, of course, we have this kind of publication, which we did not have before for the case of TCM and SARS, or this kind of webinar where we can come together and discuss things in a way that I really felt I was alone at the time, but now I feel part of this broader global network of people trying to understand what's happening in our current pandemic present. So thank you.
Thank you so much, Marta, for placing this this moment into a long sort of modern trajectory of modern biomedicine and its global responses to pandemics and to Asia, and also to others. I appreciate bringing the Ottoman example, and as you know, and some others here, I'm a great fan of the rabbit duck. I think is an excellent conversation partner. Although I think we have at least today we now need an image with 3 different images in there, because we have Tibetan, we have Chinese, we have biomedicine, here in the webinar.
Like to, Michael, if you allow, to ask from you 4. What do you think? How should we continue? How should we move on, with this webinar? Because thank you so much. It was highly impressive and informative, of course, because I think millions of people don't know even one piece of what you told. So how should we make it even, distribute and communicate even more, because still I feel we are a highly sophisticated group, of scholars and of practitioners and so on. And so may I ask you, Michael, do you agree with this question?
Yeah, great question.
Maybe people could also, yes, raise their hands and. maybe, I don't know if Tony, so Tony, if I may just say what we supported, I asked them just supported this kind of protocols, because this was always a problem. If you can establish or write down protocols, on the other hand side, protocols some biomedical physicians don't, you know, accept. But nevertheless, this is a very movable way, you know. How may I ask you? So I think, from at least in my view, according to my view, we should maybe proceed to support in this way. What's your idea?
Thank you, Angelica. Yeah, I think now we're at a point, at least in Tibetan medicine, maybe where Chinese medicine was in North America several decades ago. And I think that right now we're looking at how we can build that momentum, how we can establish much of the science as well. So working with our pharmacology colleagues, with our systems biology colleagues, we had a very limited breast cancer study that we had about 20 different formulas we wanted to use for third stage breast cancer, and only 7 were approved for IND access for the pilot study. So being able to, even at the very small level, initiate these pilot studies so we can start amassing more data and then launching, I think, larger is important. I think also working with our colleagues in Tibet, they have massive hospitals that we have thousands of patients coming in all the time, and being able to implement a lot of this research there on the ground as well, I think is going to be important. And to be quite honest, learning from our Chinese medicine colleagues that they've had decades of research in this area and coming up with study designs that are elegantly implemented. I think there's a lot of work and collaboration that can happen there.
Thank you.
So thank you for hosting this and the opportunity for that discourse as well. So.
Would you like, Martha, would you like to give a second lecture for IASTAM?
I'm happy to. Actually, what I want to say to everybody participating, I think that just the fact that you're attending and listening, you have some agency, some interest, and then that you all have agency somewhere in your world, whatever that is. You have to determine for yourself. And I just encourage each and every one of you to take those steps forward into the, you know, the future that you want yourselves and like-minded people to live in. And my little form of agency that I find is participating in webinars like this. I learned so much from my colleagues. Writing that article was, you know, not the best time. I don't have my, as Shelley and Thomas know, I promise a preface to their book. But I, you know, that is a form of agency. I am committed to doing that, you know, and this means of putting this talk together was my means to get my thoughts together for that specific end, you see. And I think that all of us have those possibilities if we are, you know, really attentive to what is presented before us as opportunities to make a difference. And I just want to encourage everybody to take those steps if they have them.
Yeah, totally agree. Thank you so much. Thomas and Shelley, please say.
Well, I think I could echo a little bit of what Marta was saying, but also if there's ways that we can find sort of avenues of cooperation within the community. I think, you know, frankly, I don't know very many of the people that are here. I recognize a few of the names, but most of the names I don't recognize. And I probably have met almost none of them. And that's probably true of many of the people here. Maybe there's more recognition, but I think if there's a way that we can sort of bring people together and find ways to collaborate, and we might find that there's a number of people that have similar ideas, but different experiences and different skill sets and knowledge, and that might be a way to sort of tie some of these loose ends together. And I think that would be really helpful and valuable for the field.
I just want to say that it's really helpful when scholars like Marta write for the public, or like, you know, Helen Tilley, Michael Stanley Baker sent me that article. There's information. You may not have, you know, the widest audience. It's not one of the being printed in tabloids or something, but you're influencing the general educated reader. And I think that's really important. I'm also working on something, we'll see where I can get it published. But I think if nothing else, something in, in the US, that we have medium.com, but just to get that information out there, I think is really influential. And I think it does start to change some people's minds and how they think about the responsibility of government, and to maybe break down some stereotypes about, who did a good job here and who didn't, and why. And I think from my end also, the personal accounts are really important. It was limited what we could say, but one of the things that happened in those stadiums that were converted to these shelter hospitals is they tried to provide a more holistic form of healthcare delivery. So they involved patients in, pushing carts around and distributing food and medicines, and they celebrated birthdays, and their stories of, there were young people that were preparing for their university exams, and other people would get together and help them study. So I think I just think that's the most effective thing in many ways, is to have that really person to person, even just beyond scholarship, but helping people to be more compassionate and sympathetic to each other, just to see that we're all folks. I think that we actually need more of that for people to just see how everyone is facing similar struggles, and they may have different responses, but they have a lot of different motivations for those responses that we can all relate to and resonate with. So I think that's a piece of it as well.
I'd like to also second, I think part of what seeing Shelley and Thomas, your presentation, was having that on the ground perspective. And I think that's one of the really compelling aspects also of Sienna Craig's work with the Endangered Language Alliance, is really having people journal in their voices, in their languages, to say what are their experiences of this pandemic. When they go testing, do they get tested? Just people's stories. And I think those get out and we hear what people are experiencing, what they're navigating, the information and misinformation they're weighing. And I think it's an incredible way to see how it's actually unfolding.
So I'm conscious of time and my role as host to note that we've reached the formal conclusion. Yeah. So I just want to say to all of you who feel, okay, I want to have, attended the full formal proceedings. You have done so, and thank you for doing so. And I want to thank all of our presenters very much. And we will continue with questions. So Leon, would you like to ask your question?
Hi everyone, I'm Leon Rocha from University of Lincoln in the UK. Thank you very much for the presentation and for organizing this event. I just have a question about, do we have a sense of how much, to what extent, if at all, the diasporic Chinese communities around the world, in the States or in Europe, to what extent they have turned to sort of Chinese medical knowledge or Chinese medicine for their sort of self-care in the past, 9 months or a year or so during this pandemic?
I could speak a little bit to that. I mean, if Singapore counts as diaspora, which is that it was prohibited to treat people with COVID. They went straight to the biomedical infirmaries, or quarantined at home. And in fact, acupuncture was prohibited, although people could continue to get herbal remedies during what they called the circuit breaker. But there were a number of articles about a lot of people, rising interest in New York, and pharmacies there suddenly getting a lot more business. That's what I have to contribute. I don't know if others have anything to say.
Well, if you venture onto YouTube, there's lots of examples of US people using Chinese medicine. And videos introducing it. It's a phenomenon, the media phenomenon that, again, did not exist when on the SARS case. So it's a really different world. And
I can't really speak to the. Sorry, I can't really speak to the diaspora in the U.S., but I can speak a little bit to the Chinese medical profession there, having been involved in some of the initial sort of transfer of knowledge from here to there, and via social media, mostly via a couple of webinars, but also Facebook groups and so on and so forth. And there were pretty quickly specific groups set up for this, the treatment of COVID-19, and being that I was the only one here. Shelley's not particularly active on social media in the US, and I tend to be somewhat. So I can tell you that the desire from the Chinese medicine practitioners, which are not necessarily, ethnically Chinese, was pretty monumental. And there was a little bit of other information coming from some other practitioners that were there that had contacts here. And however, there were also a lot of limitations with the lockdowns, and people weren't allowed to treat, or if they very quickly went to telemedicine. And I don't have, unfortunately, I don't know that there's any kind of data to support how many people were treated, what the levels of the conditions, whether it was a mild, moderate, or and certainly not serious cases. Not that I'm aware of there's anyone collecting that data, which is sort of unfortunate.
I can speak from the Tibetan diaspora perspective. One of the really exciting and fascinating things, I think, from our work so far is being able to see that there's almost a dogmatic faith in the Orthodox medicine by a lot of the Tibetan community in diaspora. And I think now that there's been a realization that there's not much that they can do, there's been this resurgence of interest and passion for Tibetan medicine, and kind of a cultural pride around that, and a lot of social media saying, oh, we actually have a lot to offer in this. Many of the webinars that have been happening have brought in a lot of our Tibetan community, a kind of a resurgence of that interest. And I think that's because in India, Tibetan medicine has been known to be really good at chronic illness and not necessarily for acute infections, and especially this kind of one so tenacious and deathly. So I think that we're really seeing that the Tibetan community itself is the one promoting it, saying, look what we have, and this renewed pride, I think, within the community, which is
it strikes me, that the model you're doing of pulling cases and developing protocols for recording them, actually, there's such a, for Chinese medicine in the US, there's the NCCAOM, there are formal bodies of practitioners which could be pulled and engaged to seek out this kind of data and collect it and collate it. If people here who are members of NCCAOM still, or connected to that, could connect up, and perhaps we can also collaborate and write grants and things like that to continue to gather more data, because all the practitioners in the US have this, are going to have their patient records. So there's certainly potential for a research project there. Just my 2 cents. But I also want to give the floor to Pratamash Karpe, who has a question. Do you want to unmute?
Yeah. Hi, good evening. Namaste, Mike. Nice to see you all after a long time. And with your permission, I would like to share some work going on in India regarding the COVID-19. So I'm a Ayurvedic practitioner. I'm also teaching a faculty in JMNRC, Goa. And I would like to tell you that Goa is the first state in India to officially start the treatment, means to initiate the treatment at the hospital levels, initiate the Ayurveda treatment in the COVID positive patient as well as in quarantine. So I was one of also the member of that committee who was involved in the designing the protocol. Also Ayush Ministry, which is consisting of Ayurveda, Yoga, Unani, Siddha, Homeopathy and Sowa Rigpa. So they also publish preventive guidelines on the ICMR website, that is the Indian Council for Medical Research. So first time the government took initiative and allowed Ayurveda and other traditional system of medicine in the preventive aspect also. And it played a very great role in controlling this mass pandemic in a densely populated country like India. Also, then our government also initiated, means it allowed the home isolation option to the mild and asymptomatic as well as a mild symptomatic, and Ayurveda practitioners were allowed to, legally they were allowed to treat these patients, and we are still generating the data. Also, we were able to reverse this infection, means the complications were, we were able to prevent the complications like pneumonia and other complications. Also, now we are planning to, at the government level, state government level, we are setting up the clinics to control the post-COVID syndromes like myalgia, loss of taste, loss of smell, and other organ associated inflammation. So first time the also world recognized that immunity is the main concept rather than just treating the disease. Thank you.
So Pratamasti, namaste. Thank you so much for all you presented. I think that one of the exciting parts, at least from the Sorikpa part of the Ayush, is that initially there was a lot of criticism by the Indian government, causing the Sorikpa practitioners to not be allowed to offer medicines and not be allowed to actually offer their donations. And Mensikang was under a lot of criticism initially for making wild claims that they could treat COVID. And that has changed because of Ayush's support and being able to show that Tibetan medicine can actually head off a lot of the preventative aspects or the recovery aspects, and that's where we're seeing a lot of the precious pills being put into. So it's wonderful to hear that in Goa now you guys can integrate Ayurveda as a front line into a lot of these cases. So it's been a wonderful transformation over the last several months, I think, that we've seen as well. So thank you.
May I say one word? Thank you all so much for this great webinar. I've learned so much. Thank you, Marta. Thank you, Thomas. Thank you, Tony. Thank you, Michael. You have the last word, of course. It was great. So I hope we will continue. You can suggest. You can make suggestions. Maybe within a month or within 2 months, or we should have another one, and you can shape it. Michael, and also to you from India, I think it was, we have recorded it, so we will save it. We will not die today. And Michael, you have the last word. Thank you so much to all of you and to all the listeners. And you can also write emails, of course, maybe if you think about, and then you think, you can write your suggestions for better for the next time. Yeah.
Absolutely. Thank you, Angelica, and thank your amazing presenters and great audience and great questions. I think there's it feels like this is the beginning of a conversation.
Yes.
And there's much more to unfold. I think Marta, you're right. We won't know what's happened, for another 10 years, if that.
But can I don't want the last word. I just want to say we can influence how we understand this over the next 10 years by making visible what's happening right now.
Yes.
And that's our power.
Yeah. Yeah.
Well, on that note, I mean, our plans, I'm co-editing with Ronit Yoli-Tlalem, who's here in the screen somewhere. An edition of Asian Medicine, an issue which will be featuring the presenters who you've heard today. And hi, Ronit, do you want to add anything?
Well, just first of all, thank you for everyone. It was really extraordinary. I want to second what Angelica, Shelley, and Marta said in different ways about our role in influencing. And I think Marta's presentation was really helpful to think about the role of the media, and we have to try and play a role in influencing the media, because that can have a really important impact. So yeah, thank you all. It was really fascinating, and I look forward to the next round.
Thank you, Ronit. On that, in addition to the Asian Medicine, I'm also in touch with a writer for the New York Times, who's agreed to write up our issue of Asian Medicine and this seminar. So those of you who want to contribute, have a voice, please be in touch. We also want to write something for for the mainstream biomedical journals, for the Lancet, BMJ, JAMA, something. Those of you who want to be involved in that, contribute, please be in touch with Ronit and myself, because the more authors, the better. I think for this, because we can really ensure a complete, well-rounded presentation both of the cases and of the kind of epistemological arguments that we want to present. So in terms of the advocacy, this is where, you know, I think IASTAM can really make a difference. And also, you know, connecting with other research bodies like NCCAOM or other kind of formal bodies that may feel like we're busy, yeah, that you know, may like to have companions in generating this discourse. So with that, I think I'll just thank you all, and I look forward to seeing you around.
Bye-bye.